All right, welcome to week 2. This week we're going to be talking about infection control and diagnostics. After you review the PowerPoint outside of class, once you go to class you will be doing an in-class assignment and activity, so be sure you pay attention and participate. These are the objectives for your course. I'm not going to read each of these to you. But please read through them so you know what to expect for this week. Okay, so like I said, we're going to be talking about infection control and diagnostics. This slide gives you a good picture of how we can prevent the spread of infection, and epidemiology focuses on where we can break the chain of infection. So as you see here, you need a few things. You need an infectious agent, which can be your bacteria or your viruses. You need a reservoir. This could be people, this could be equipment, this could be water. And you need a portal of exit. So your secretions or body fluids, droplets, your skin. And these viruses or bacteria need a means of transmission. So how are they getting there? Is it direct contact? Is it airborne? Is it droplet? Is it ingestion? And then they need a way to enter into the next host. So is this via their mucous membranes, their GI tract, inhalation, broken skin? And lastly, they do need a susceptible host. So this doesn't always mean that you have health issues, but they do need somebody susceptible. So this could also include immunosuppression, which are higher at risk, your diabetics, your people who recently had surgery, burn patients, things like that. So how do these diseases transmit? And these are just a few examples. We know there's airborne, there's also foodborne, waterborne, direct contact. So these are how our bacteria and viruses are transmitting. So let's talk about airborne for a minute. Airborne particles are approximately 1 to 5 micrometers in diameter. So they are so tiny that they can remain in the air for long periods of time, and they can be transmitted over greater distances, even more than 1 meter. So this is why for airborne precautions in the hospital, we typically have to have a longer period in between patients in terms of an ISO-clean. So I'm sure you guys have heard the term ISO-clean before, that we need an ISO-clean on such and such bed before we put the next patient in there. And we usually have to wait a longer period of time than, say, influenza, because influenza is droplets. So airborne, these particles remain in the air for a longer period of time, and we have to wait for them to drop to the ground and then clean it. So particles smaller than 5 UMs, this is just the measurement that we use, they're widely categorized as aerosols, again able to float in the air longer and penetrate far deeper into the lungs. Examples of this would be measles, which also happens to be direct contact and droplet. Chickenpox, again, also happens to be direct contact and droplet. TB and SARS. So let's talk about droplet. So droplet is greater than 5 to 10 micrometers in diameter. So these are larger than 10 UMs and are usually or easily intercepted by the upper airways, meaning your tonsils and your nasal passage. They can easily track these more easily than airborne. And again, these particles tend to fall to the floor or surfaces, and they can remain there for a longer period of time. And examples of this would be influenza, meningitis, pertussis, strep, things like that. So what puts an individual at higher risk for infection? So we know very well that things like smoking, alcohol use, Drug abuse, specifically IV drug use, can put a patient at higher risk for infection. Poor diet, personal hygiene. Why do you think lack of time management is on here? Well, if you look at it from a nursing perspective, if you aren't managing your time well and you're running from patient to patient to patient, eventually your ability to slow down and remember to do hand hygiene or to wipe off your supplies, things like that, it becomes greatly diminished and you increase your risk of infection. It also creates higher levels of stress, which suppresses your immune system. Again, from a nursing perspective, but also including our friends and family who are in other fields working overtime, long hours. This again increases stress and suppresses immune system and it makes you more tired and more susceptible to infections. However, the risk behavior that puts you at the highest risk for infection is actually a knowledge deficit related to infection control. And this has been proven over and over that we need to simply educate people, and the lack of education is what makes them the greatest, puts them at the greatest risk for infection. So how can we prevent or control the transmission of infectious agents? Well, we need to develop and review infection prevention and control policies and procedures. We usually have hospitals have a team of people that do this, and this is their job. We need to collaborate with public health agencies in planning community responses to biological agents. So we saw this a lot during COVID. Different hospitals were collaborating with our public health agencies and figuring out what the best response was to this pandemic and figuring out how we need to manage it in our area. The third thing we need to do is identify and implement infection prevention and control strategies according to specific topics. So there's a lot of different ways that we're going to say we need to control infection or prevent the spread of infection, but we need to categorize it so that it's not just a bunch of information thrown at staff members. So dividing topics by hand hygiene, how we clean and disinfect our equipment, what are our diagnostic procedures and devices that we're using during those times, and how do we prevent infection during diagnostic testing, whether minimally invasive or highly invasive, how we use isolation, patient placement, what are their policies, how do we figure out if we have a COVID patient where that patient is going to go, which unit, which room. Patient placement is highly involved in that. Waste management. Where do our waste products go? This has been a huge topic lately in the hospital because we got dinged on it and fined for not putting waste products in their appropriate bins. Immunization programs. We've seen a lot of this again with COVID and our policies and procedures for our staff members and which immunizations they're required to have. So just to review the basics of infection prevention, obviously hand hygiene is still the number one. How we utilize our PPE is very important. How we take it on and how we take it off and what we do in what order, it does matter. Creation and adherence of adherence to infection prevention bundles. So the types of what kind of bundles have you guys seen in the hospital? This could be the sepsis bundle. How do we properly take care of a septic patient and prevent further infection? We've created bundles for this, meaning protocols that we follow every time the same way in order to most effectively prevent further infection. And again, training and knowledge of our ancillary services and their roles. So, ancillary services being like the cafeteria or our waste management, our EVS, our environmental services, um, our dispatch people, what are their policies and what is their training, things like that. This is just an example of our ancillary services. So how many different areas we need to consider um, for their policies and procedures, and how every area has um, their own policies and their way of adhering to their procedures in order to prevent infection. And so if you were working in a department like infection prevention, you would have to look at all these ancillary services and make sure that they're all addressing how they best prevent the spread of infections. So I put this slide here because it's important for you to pay attention to for your exam. Hand hygiene is the single most important way you can prevent infection, and you should not be missing this question on your midterm because I'm highlighting it for you here. Hand hygiene is the single most important way you can prevent infection. So there's a couple different kinds of soaps. This is a nice graphic that gives you an idea. So plain soap is good, antimicrobial soap is better, but alcohol-based hand rub is best in terms of killing bacteria. Obviously, it's not always appropriate to use alcohol-based hand rub, especially in certain situations like C. diff, where you need to physically rinse the germs off of your hands because of the high susceptibility rates of um, infection spread and how contagious C. diff is. But in killing bacteria, alcohol-based hand rub is actually the best. And just remember that antimicrobial soaps and other hand washing soaps, their job is mostly to rinse the bacteria off of your hands, not necessarily killing it. Okay, so this is another nice little chart for you. You might want to highlight this slide and the prior slide. So the routine hand washing, again, its purpose is to remove soil and transient microorganisms, and obviously we want you to wash your hands for 20 seconds. Hand antisepsis is removing or destroying transient microorganisms, and this is your antimicrobial soap and water for at least 20 seconds. Your hand rub, this is your degerming agent, so we're destroying transient and resident microorganisms, on unsoiled hands. So these are your alcohol-based hand rubs, and you need to rub it until it is dry. And your surgical hand scrubs. So these are removing and destroying transient microorganisms, and in addition, they reduce the resident flora on your skin and leave an antimicrobial residue on the skin to prevent growth of microbes for several hours. This is a 3-minute scrub solution that you need to scrub with for 3 minutes, and obviously this is largely used in the OR as people typically have their hands on these patients and inside their body tissues for longer periods of time. Also, the NICU nurses tend to use these, especially on their patients who are preemies or immunosuppressed or have other disease processes going on. Okay, so why do we care about fingernails? Well, there's a reason that we don't allow nail polish or gels, and that's because the bacteria, once it is stuck to the polish, it's there. it's not really going anywhere. And the little grooves or scratches that get into the polish, the bacteria can nicely snuggle in there and hide and stay away essentially from your hand soaps and the alcohol-based hand rubs. There was actually a case about 5 or 7 years ago at Eisenhower, where there was a baby that in the NICU that got very sick, and they actually traced the bacteria in this baby's blood to her nurse's gel nail polish. So they found the same bacteria in her gel nail polish. So it's very serious. We don't just have this rule just because we want you to look extra clean and spiffy. The bacteria really do stick to that polish and it does not come off. If you do happen to have an allergy to some of the hand hygiene products, this needs to be reported to your employer because occupational health will evaluate you and they are actually required to provide alternate products to employees who are having allergies. PPE, this is a OSHA requirement or Occupational Safety and Health Administration requirement. And the definition of PPE is that it's specialized clothing or equipment worn by an employee for protection against infectious materials. You guys should have all had experience with this by now. This is not only to protect you, but it's also to protect the patient. In cases of like chemo and immunosuppression and things like that. So I wanted to show you guys this because this is an example of an infection prevention bundle that somebody created. So this is your 7S's bundle to prevent surgical site infections, or SSI. So this looks at safety of the operating room, screening for presence of MRSA or MSSA, ensuring or encouraging showers of the patient the night before and the morning of surgery, skin prep, using appropriate skin prep material for antisepsis, solutions, so which solutions we're irrigating tissues with prior to closure, sutures, if we're using antimicrobial sutures, and skin closure, so are you sealing the incision or covering it with an antimicrobial dressing? So, who more than the hospital administrators care about our infection prevention methods? Well, Joint Commission certainly does. Usually, you hear nurses talking about, oh no, Joint Commission is coming. Joint Commission is an accreditation that hospitals pursue because it's required in order to receive payment from federally funded Medicare and Medicaid programs. So do we care about preventing infection to our patients? Yes. Do we want the best outcomes for our patients? Yes. But we also won't get paid if we aren't accredited and meeting infection prevention standards set forth by the Joint Commission. So in 2020, 62.6 million people were enrolled in the Medicare program. So can you imagine if we were treating, we wouldn't probably be treating all 62 million people in the Medicare program in California, but we would be treating a large population at our hospital. So let's say we treated 1 million. It would be devastating if we didn't meet these criteria and weren't reimbursed by Joint Commission for our infection prevention standards because we weren't meeting those benchmarks. Joint Commission focuses on patient safety and quality of care, and they have more than 250 accreditation standards. These largely focus on infection control, medication management, and preventing medical errors. So obviously there has been a lot of research into infection prevention, and that's what has really guided our policies and procedures. for preventing infection in our hospitals is these research studies. Well, how can we trust that these studies are accurate? How do we know that what we've based our decisions on, that these studies have provided accurate information? And we're going to review some of that, which are including some of the terms from your reading this week. So validity is a term that's used to describe the degree to which data measures what it was intended to measure. So meaning how valid is your study? To what degree do the results of a measurement correspond to the true state of the phenomenon that's being measured? You can find a little bit of a longer description on page 33, but ultimately, when we're talking about the validity of a study, we're saying at what degree did it measure what we were intending it to measure. So how do we know if something is valid or accurate? It is measured by or compared with an accepted standard. So, for instance, how do you ensure the validity of a glucometer? Well, you have to do quality controls on it. And you do this by, hopefully some of you have experience doing this or have seen it, but you basically have little vials that have high and low blood sugars on them, in these vials, excuse me, and they're testing vials. So it makes sure that the glucometer knows that when you scan the vial of, say, high blood sugar, that it's supposed to be reading high. And when you test it, it says, okay, yes, I read this correctly, or, well, it was supposed to be high, but I didn't read high, so something must be wrong. So we are making sure that that these measurements are valid. How would the validity of an ultrasound or other radiologic examination be verified? So they have to go through their own quality controls, and we have to make sure that they are giving us information that is accurate, and we use our other standards and our other measurements of these in order to compare it to what is acceptable. What about subjective measurements like pain or nausea? We have tools and measurement tools that we use, like the pain scale, to figure out if it's valid. And how do we know if it's valid? Because we put the pain scale of 1 to 10 under vigorous study and found that these numbers did in fact correlate to these higher or lower pain scores, and that these medications that we deemed appropriate for those scales did work to decrease the patient's pain. So they went under extensive study as well. So how do we know if a test is reliable? The definition of reliability is the extent to which repeated measurements of a stable phenomenon by different people and instruments at different times and places get similar results. So, meaning you need to be able to repeat the test in different settings with different instruments and at different times and different places in order to understand if this is a reliable test. And in all of these differences, you're getting similar results. So what might be some examples of a reliable test? Well, for example, a troponin. If we are able to repeat that troponin test with different patients in different settings, or the same patient in, say, with slightly different instruments, or point of care glucose, right? We've done this test several thousand million times on different patients with slightly different instruments, but we're getting similar results. So that's how we know that a test is reliable. So when we're talking about diagnostics, these are some of the terms that we're going to be using. True positive, true negative, false positive, false negative, insensitivity, and specificity, which we will go over in some more detail. The true positives and negatives and and false positives and negatives. These are slightly straightforward, but we're going to review them as well. So first, let's talk about what a diagnostic test is. Typically, when you ask this question, most people think of a test that's being performed in a laboratory. But you can have diagnostic assessment findings. So, for example, if you think about the symptoms of a migraine, or if you think about the symptoms of appendicitis, usually you can have diagnostic clinical findings for certain conditions that allow you to definitively say, yes, this is this disease, and you, of course, can back it up. Say appendicitis, you can back it up with a CT scan. A migraine, you do more diagnostics based on symptoms and severity of symptoms. Okay, so when we have a true positive test, it means that the test has given us the correct result when it is positive in the presence of disease. However, a true negative is when the test is given the correct result when it is negative in the absence of disease. So basically, you're getting the correct result of both positive and negative in the presence or absence of disease. Now, a false positive means that the test was positive, but the disease is absent. And a false negative is that the test is negative, but disease is actually present. Let's talk about sensitivity. So, a sensitivity of a test, the definition from your book says the proportion of people with the disease who have a positive test for the disease. So we're talking about people who have the disease. A sensitive test will rarely miss people with the disease. So an example of this might be a pregnancy test. They are, as you can sometimes see at the grocery store, on the box they'll say 99.9% accurate. So this test will rarely miss people with the disease. Now, specificity is the proportion of people without the disease who have a negative test. So a specific test will rarely misclassify people as having the disease when they do not. So an example might be an EKG. If you come in with chest pain, it's not going to show elevated T waves when they don't have when they're not having a heart attack. So what are some instances where you can think you would want a highly sensitive test? Usually these types of tests are very important when you're trying to determine if somebody has cancer. So you definitely want highly sensitive tests when you're talking about potentially fatal or misdiagnosing it or missing it would have high consequences. So again, you want a highly sensitive test when there is a high penalty for missing the disease. And some examples could be, cancer, Hodgkin's lymphoma, a DVT, HIV, pregnancy, etc. When we're using a highly specific test, it's usually because we're trying to confirm a diagnosis that might be suggested by other data. So we're actually trying to rule in a disease because a highly specific test is very rarely positive in the absence of disease. So you really want this kind of test when a false positive can be harmful to the patient, whether it's physically, emotionally, or financially. An example would be, again, a test for cancer before initiating chemotherapy. A D-dimer. A D-dimer is usually very non-specific. So a D-dimer will pop positive if you've had any sort of clotting within the last 30 days. So it's actually not very useful in determining a current DVT. You need it really with other tests such as an ultrasound, um, in order to see if it's giving you a reliable value. Let's talk about cutoff points. So cutoff points are very important. These are what we use to determine if somebody has a disease or not. So for example, we use cutoff points to determine if somebody has diabetes. We say over this A1C value, this person has diabetes. We say over this blood sugar value, this person is hyperglycemic, or under this person is hypoglycemic. So cutoff points are used in every test we do that has numerical values, like blood pressures, like troponins, like your creatinine. All of those things have cutoff points. And it helps determine whether you have an abnormal or a normal value. These cutoff points are sometimes an arbitrary decision, but the choice can change the sensitivity and specificity of that test. Now, through lots of research, we've been able to determine things like, for example, blood sugar, because it's been studied so extensively. We have pretty accurate cutoff points. But when you're starting off with new tests or things like that, sometimes you kind of choose a value and you research it and you play with it until you find what patients are responding to the best in terms of how we treat or not treat certain values. So let's talk about cutoff point in relationship to high sensitivity or low sensitivity and specificities. So here you have an example of a BNP, and this BNP value, say 50, has a sensitivity of 97% and a specificity of 62%. So if the cutoff level of the test is too low, sensitivity is going to be high, but the trade-off is low specificity, which would require many patients who may not have congestive heart failure to undergo further testing for it. So another example would be if you decided that you wanted to diagnose diabetes with an A1C of, say, 3, you would definitely have very high sensitivity, but you would be including a lot of people who don't actually have diabetes, and you may end up harming this patient. So for cutoff points, if the cutoff level of the test is too low, sensitivity is going to be high, but you will have low specificity. And the inverse is true of a high cutoff point. So again, let's say for diabetes, if you determined that people should be diagnosed with diabetes who had an A1C greater than 10, well, you would have very low sensitivity, but a very high specificity. That concludes our lecture for this week. In class, you will be completing an infection control activity with Professor Solons. If you have any questions regarding this PowerPoint or the information, you can ask Professor Solons, and she will be able to answer your questions.